Hey guys, and welcome back to Confessions of a Doctorholic. If you're new here, my name is Hafsa. I'm a general surgery resident in the States, and this podcast is where I share real stories from inside the hospital, the fascinating cases, the strange moments, and sometimes the emotional side of medicine that people outside the field rarely see. Today's story is about something I honestly never thought I would see in real life: Stevens-Johnson syndrome. If you're not in medicine, Stevens-Johnson syndrome is a rare but very serious condition where the skin and mucous membranes start to break down. The top layers of skin separate from the body, and it can look very similar to a sunburn, but a really bad, severe one, involving your whole body and including your mouth and your nostrils and your vagina and your asshole, like literally every orifice that you can think of. It's something we learn about in medical school, but it's rare enough that many doctors will go their entire careers without seeing a case. And during my burn rotation, I saw something that looked exactly like it. This patient had stage 4 cervical cancer. She had already gone through multiple treatments, chemotherapy, other systemic therapies, and eventually her oncology team started her on pembrolizumab, which is a type of immunotherapy. I'm actually proud of myself for pronouncing that without hesitating. Immunotherapy works differently than traditional chemotherapy. Instead of directly attacking the cancer, it helps the immune system recognize and fight cancer cells. And for this patient, it actually seemed to be working. After her first treatment, they did a scan that showed her cancer burden was decreasing, which in oncology is a huge moment, because when you're dealing with advanced cancer, finding something that actually works can be incredibly meaningful. But then something unexpected happened. She developed a rash. At first, it seemed mild. The oncology team treated it with steroids, which is often the first step when someone develops an immune-related reaction to immunotherapy. And initially, the rash seemed to improve. But then things got worse, much worse. Her skin started peeling, large area of her skin began to separate. And when that happens, doctors immediately start thinking about conditions like Stevens-Johnson syndrome or toxic epidermal necrolysis, which are severe skin reactions that can be life-threatening. At that point, she was transferred to the burn unit, and that was the first thing that surprised me, because I had never really thought about where these patients go or what happens to them next. But it makes sense, and it's incredibly painful. In general, second-degree burns are incredibly painful because you're not burning off your nerves. So the regrowth is when most patients complain about when they feel irritation or a burning sensation. Burn units are uniquely equipped to care for patients who have lost large portions of their skin barrier. And when skin starts peeling off in conditions like Stevens-Johnson syndrome, the body faces many of the same challenges that burn patients do: fluid loss, infection risk, pain, temperature regulation. So burn teams are often the ones who help manage these cases. When I first saw her, it was honestly shocking. Her skin looked like second-degree burns across large portions of her body. Areas were blistering, other areas had already peeled, and she told us something that stuck with me. She said the pain was excruciating. Skin is our largest organ, and when that protective layer is damaged, even simple things like air touching the skin can be painful. But there was another layer to this case that made it even more difficult. We had to stop immunotherapy, and that was devastating because this treatment was the first therapy that had actually started reducing her cancer. So suddenly we were faced with a terrible trade-off. The treatment helping her cancer had triggered a severe reaction that was now threatening her skin and overall health. And sometimes, or to be honest with you, most of the time in medicine, it's multifactorial. No single case is the same because there's so many different aspects to it that you have to think about. The one point we had to bring her in for wound care under conscious sedation. For people who haven't seen this before, burn wound care can be extremely painful. That involves like washing off the wound, peeling off things, peeling off dead skin, which is why we often provide sedation so patients can tolerate the procedure. They're awake, but they're essentially in deep sleep. During the procedure, we gently wash the areas that were affected, clean the wounds, and apply protective skin dressings to help the skin heal. These dressings help prevent infection and create an environment where the skin can regenerate. Even though the patient was sedated, the whole process was emotionally heavy. And you can imagine how this may have affected her. So after Stevens-Johnson syndrome suspected diagnosis, usually what we do is the dermatologists come in, get a skin biopsy. And yes, dermatology does far more than just Botox. But they do a skin biopsy, and usually dermatopathologists see it under the microscope. And they can say, we think based on what we see that it's most likely Stevens-Johnson syndrome, but we still wait for the official read. So these pathology results eventually came back, and surprisingly, it wasn't actually Stevens-Johnson syndrome. It was a rare immune-related skin reaction to pembrolizumab that closely mimicked it. And that's something that happens more often now that immunotherapy is becoming more common. These medications are incredibly powerful, but because they activate the immune system, sometimes the immune system starts attacking healthy tissues as well: skin, lungs, liver, and in this case, the skin. This case stuck with me for a few reasons. First, it reminded me of how complex modern medicine has become. We now have treatments that can dramatically change cancer outcomes, but those treatments sometimes come with side effects that we're still learning how to manage. And second, it reminded me how important burn units are. Most people think burn units only treat fire injuries, but they also care for patients with severe skin conditions, medication reactions, explosions. It's a specialty that sits at this fascinating intersection of surgery, critical care, and wound healing. Seeing this case made me realize something else today. Sometimes in medicine, we celebrate the treatments that work, but we don't always talk about the moments where treatments help in one way, but hurt in another. And those moments are some of the hardest ones for patients and doctors to talk about, because there's rarely a perfect answer. So, my confession for the day. Some of the most difficult cases in medicine aren't the ones where we don't have treatments. They're the ones where every option comes with a trade-off. Before I wrap up today's episode, I'm curious about something. Wherever you are, whatever field you're in, tell me something rare that you learned about in school but never expected to see in real life.